All right, welcome to the deep dive. Today we're cracking open a specific set of notes, really getting into a condition that affects quite a lot of people, often tied to the seasons changing seasonal affective disorder, or SAD.
That's right.
Think of this as your, high-yield guided tour specifically aimed at helping with revision, our goal. Unpack everything crucial from these notes, pull out the absolute must-knows, and help make it stick.
Yeah, understanding how things like, well, the environment, particularly light, can impact mental health is so relevant, and these notes really lay it out. It's fascinating, that link between our biology and, well, the world around us.
It really is. So let's jump straight in. According to these notes, fundamentally, what is seasonal affective disorder? What's the sort of core definition we need to grab onto?
Well, at its heart, SAD is defined as a type of depression that follows a really distinct seasonal pattern.
Hmm.
The notes are clear. Typically, it starts in autumn or winter, and that's linked directly to less sunlight. And then, importantly, you see the symptoms go away, remit in spring and summer. The key thing for diagnosis is that it involves recurrent depressive episodes year after year.
Right. Okay, so it's not just feeling a bit down in winter, the winter blues sort of thing. It's a clinical repeating pattern tied specifically to the seasons.
Precisely. Yeah, it's often called winter depression. That's the common name. Though the diagnosis itself has had a bit of a, let's say, controversial history. It only really got formal recognition back in the 1980s.
Ah, okay.
And the notes are quite specific here, pointing out that these recurring episodes, if they get severe, can potentially lead to hospitalization. That really underlines how serious it can be. The source ties it directly to light changes affecting our biological clock, and crucially for clinical practice, it says it's generally treated like other types of depression, following NICE guidelines. Usually starting with psychological therapies, maybe considering SSRIs, those are the selective serotonin reuptake inhibitors, common antidepressants, but advising against routinely using sleeping tablets. And it notes, at least in this overview, that the evidence for light therapy as a routine first step is seen as limited.
Understood. So the absolute core concept, the anchor for revision, is basically depression with a recurrent seasonal pattern. That's the foundation.
Exactly. That's the key.
Okay, let's unpack that a bit more then. The notes mention complex causes, the etiology. What actually causes SAD? What's going on underneath?
Yeah, it's definitely not just one thing. It's more of a complex mix. You've got genetic factors, biochemical stuff happening in the brain, and environmental influences all playing a part.
And the big environmental one is sunlight.
That's the major player highlighted, yeah.
Yeah.
The reduced sunlight we get in winter. The thinking is that this lack of light messes with our circadian rhythms, internal body clock, and that leads to imbalances in key brain chemicals, neurotransmitters, especially serotonin and melatonin.
So less light throws off both your body's timing and its chemistry. That seems pretty fundamental.
It is. The notes specifically mention phase-delayed circadian rhythms as being involved. They also touch on a possible genetic predisposition and maybe abnormalities in the pathway from the eye to the brain's clock center, that's the retinohypothalamic tract, and the pineal gland, which makes melatonin.
And you mentioned genetics playing a role, too.
Yes, definitely. How sensitive we are to light seems to have a genetic component. The notes even mention links to specific gene mutations, like in the melanopsin gene, which is involved in how our eyes detect light for regulating those circadian rhythms. It helps explain why SAD sometimes runs in families.
Right. And this is where it gets really interesting, doesn't it? This direct biological connection between something external, like light, and our internal mood. Do the notes link this back to why treatments work?
They absolutely do. It gives the biological why. For instance, light therapy, the idea is it works precisely because it influences melatonin secretion and helps boost serotonin levels. It really reinforces that serotonin is key here. And the notes also suggest that things like melatonin receptor agonists, there's a medication called agomelatine mentioned, and even just regular exercise might be effective, which makes sense if you're targeting these biological pathways.
That really ties it together. So, quick revision check. If you were asked about the mechanism linking winter and SAD, what key biological pathways from the notes should definitely be mentioned?
You'd absolutely want to hit on the disruption of circadian rhythms, the impact of reduced sunlight on serotonin and melatonin levels, the genetic links we talked about, and potentially issues with those light-sensing pathways from the eye, like the retinohypothalamic tract.
Perfect. Got it. Now, thinking about who gets this, who's more likely to experience SAD? What risk factors do the notes outline for us?
Okay, the notes give a pretty clear picture. A big one is living at higher latitudes.
Ah, like further north.
Exactly. The further you are from the equator, the less winter sunlight you get, basically, and the higher the risk. That fits with the epidemiology we'll touch on later.
Makes sense. What else?
Other key factors listed are having a family history of SAD or other mood disorders like depression or bipolar. Being female, it's consistently shown to be more common in women. And having a personal history of depression or bipolar disorder yourself.
Okay, so for a quick memory hook, you could maybe think location, latitude, family history, gender, female more common, and personal history of mood issues. That seems to cover the main risk factors from the notes.
That's a good way to summarize them, yeah.
Now, how does all this biology actually translate into changes in the body? What's the pathophysiology described in the notes? How does it work physically?
Well, the pathophysiology section really just reinforces what we discussed under etiology. It details how that disrupted brain chemistry and body clock actually, manifest. It boils down to those changes in neurotransmitters again, mainly serotonin and melatonin, and the disruption to the body's internal clock, the circadian rhythm.
Can you just quickly recap the light mechanism again, as described in the notes?
Sure. So normally, bright light exposure signals the brain through those special cells in the retina, the retinal ganglion cells. This signal tells the pineal gland to suppress melatonin production, keeps you awake and alert.
Right.
But in winter, with less light, that suppression signal is weaker. So the notes explain this leads to increased melatonin, making you feel sleepy, sluggish, and at the same time, decreased serotonin levels. It's that combination that's thought to drive the mood changes and throw the circadian rhythm out of whack in SAD.
Okay, so the simplified version is less winter light leads to more melatonin plus less serotonin, which equals mood changes and a messed up body clock.
That's the core mechanism the notes are describing, yes.
Got it. Okay, changing gears slightly. If someone comes in with low mood, specifically in the winter months, what else could it be? It's not automatically SAD, right? The notes list several possibilities, the differential diagnoses.
Absolutely crucial point for assessment. You have to consider other conditions. The notes list quite a few. First, major depressive disorder, just, regular depression that doesn't necessarily follow that seasonal pattern.
Okay.
Then, bipolar I and bipolar II disorders. This one's really important. The notes specifically say to consider bipolar if someone has depression starting in autumn-winter, but then they have periods of hypomania or mania in spring-summer. That seasonal switch is a big red flag for bipolar.
Right, that's a key distinction.
Definitely.
Yeah.
Also on the list, dysthymic disorder, that's a milder but more persistent depression. Cyclothymic disorder, milder mood swings. Premenstrual dysphoric disorder, PMDD, that's tied to the menstrual cycle phases. The notes mentioned that specifically. Then you've got things like chronic fatigue syndrome. Hypothyroidism, an underactive thyroid, is a classic mimic for depression symptoms. And, of course, you need to consider substance misuse and alcohol misuse, too.
Wow, that's quite a list. So a good memory tip for differentials might be to think broadly. Other mood disorders, especially bipolar, hormonal issues, thyroid, PMDD, fatigue, substance use, rule those out.
Exactly. Clinical assessment is vital to tell them apart.
Okay, moving on to the numbers. What do the notes tell us about how common SAD is? The epidemiology.
Yeah, the notes give some useful stats. It's estimated to affect somewhere between 3% and 8% of the UK population.
So not insignificant.
Not at all. And confirming that latitude risk factor we talked about, it's significantly more common in northern parts of the UK compared to the south, and just generally more common in countries further away from the equator.
Right, the latitude link is clear in the numbers then.
Absolutely.
Yeah.
It typically tends to start in young adulthood, and as we mentioned with risk factors, it's more prevalent in women. The notes also reiterate that genetic component, higher risk if you have close relatives with SAD. And there's an interesting nuance they mentioned. A seasonal pattern is actually seen in about 15% of patients who already have recurrent mood disorders. So while SAD is its own diagnosis, seasonality can pop up in people with other types of recurrent depression too.
Okay, so what's the big picture from the epidemiology? It's not rare. Where you live matters a lot. Latitude, and there's a clear demographic lean towards younger women.
That sums up the key epidemiological points from the notes nicely. Yeah.
Right. Now let's get really specific. What does SAD actually look like? What are the typical signs and symptoms, the clinical features, and how is it diagnosed based on this material?
Okay, so the notes start with the standard depression symptoms you'd expect. Things like persistent sadness, low mood, losing interest or pleasure in things, fatigue, changes in sleep, changes in appetite or weight, difficulty concentrating, maybe feelings of hopelessness or worthlessness.
The usual suspects for depression.
Yeah.
But then there are the more sort of SAD-specific symptoms.
Exactly. And the notes really highlight these because they can help distinguish SAD from non-seasonal depression. These often include increased sleep duration and hypersomnia, significant cravings for carbohydrates.
Ah, the carb craving. Hear that a lot.
Yes. Increased appetite generally, leading to weight gain, social withdrawal, wanting to hibernate almost, irritability, difficulty waking up in the morning, decreased energy, feeling lethargic, decreased libido, and difficulty concentrating again. The notes also throw in things like family problems, tearfulness, headaches, even palpitations as possibilities.
That cluster of increased sleep, carb cravings, increased appetite, and weight gain really does sound different from the classic picture of depression, which often involves less sleep and appetite.
It really does. And the notes specifically point to that increased appetite and carb craving as a characteristic feature that's useful for diagnosis. But the absolute most critical diagnostic feature, the one that overrides everything else, is the seasonal pattern.
It has to come back each year.
Yes. The symptoms must recur and remit around the same time each year for the diagnosis to stick.
And is there a minimum time for that pattern?
Yes, the diagnostic criteria mentioned state it's based on those characteristic features of mild to moderate depression, a recurring seasonal pattern for at least 2 consecutive years, and crucially, ruling out other potential causes for the symptoms.
2 consecutive years. Okay, that's key. Do the notes mention different types or variants of SAD?
They do. They list the most common one, autumn-winter onset, which gets better in spring-summer. There's also a milder form called subsyndromal SAD. Symptoms are there, but less severe, less impairing. And then there's a much less common summer onset SAD, which actually gets better in the winter.
Interesting.
They also describe a typical progression for the common winter type. Symptoms often start developing September through December. It might begin with difficulty waking up, then progresses to decreased energy and lethargy, then those characteristic carb cravings, increased appetite, sleeping more, weight gain, followed by difficulty concentrating, lower libido, and social withdrawal.
Okay, so a definite memory tip here seems to be focusing on those winter hibernation symptoms. The carb cravings, sleeping more, weight gain, pulling back socially. Comparing those to typical non-seasonal depression symptoms like insomnia and loss of appetite is probably a high-yield distinction for revision.
Absolutely. And maybe frame it as a question for yourself. If a patient describes low mood and fatigue only in winter, and specifically mentions wanting lots of bread and pasta, what diagnosis jumps out, and why are those food cravings such a useful clue according to these notes? That scenario is pretty classic SAD based on this material.
Right, that paints a clear picture.
Right.
So how do doctors actually confirm it's SAD? Are there specific tests they run? What do the notes say about investigations?
The notes are really clear on this. The diagnosis is primarily based on clinical assessment. It really relies on taking a thorough history from the patient, listening carefully, and assessing their symptoms against the criteria. There aren't any specific lab tests or imaging scans that can directly diagnose SAD itself.
So no SAD blood test or anything like that?
Nope, nothing like that. However, investigations are important, but their role is to rule out other underlying medical conditions that could be causing or mimicking the symptoms.
Ah, okay, so it goes back to that differential diagnosis list we talked about, making sure it's not something else.
Exactly. The standard investigations listed for ruling out physical causes include basic blood work, FBC, full blood count, UNEs, urea and electrolytes,
Right.
LFTs, liver function tests, and very importantly, TFTs, thyroid function tests, because hypothyroidism symptoms can overlap significantly.
Right, thyroid check is key.
Yeah. They also list glucose and calcium levels and hematinics, which check things like iron and B12 levels. Then, depending on clinical suspicion, they might do toxicology screens if substance misuse is a concern, maybe endocrine or hormone profiles, or even neurological assessments like a CT or MRI scan or an EEG in specific cases, but that's less common.
So the tests are really about exclusion, confirming it's not something else, rather than positively identifying SAD.
Precisely. The diagnosis really hinges on putting the pieces together. The characteristic clinical picture, that crucial seasonal pattern recurring for at least 2 years, and having systematically excluded other possible explanations. The notes also mention that structured interview tools, like something called the PSI-DAYS-AID, can help standardize the symptom assessment.
Okay.
And one really crucial point they make for the clinical examination is to always assess for suicidal ideation and any abnormal coping mechanisms the person might be using.
Right, safety first. So what this really means for diagnosis is it's about careful listening, pattern recognition, connecting the seasonal dots and specific symptoms, and ruling out other stuff, not about waiting for a lab result.
That's the essential takeaway for the diagnostic process described in these notes, yes.
All right, great. Let's move on to management then. Once SAD is diagnosed, what do the notes say about how it's treated? What are the options?
Okay, management. The notes break it down into non-prescribing and prescribing approaches. And often, the non-prescribing strategies are the first line.
Makes sense. What falls under that non-prescribing category?
Well, key lifestyle advice is big. Things like maximizing exposure to natural sunlight, trying to get outside, especially in the morning hours, even on cloudy days. Regular exercise is consistently recommended. Maintaining a balanced diet and trying to make indoor environments, like home and work, as bright and well-lit as possible.
Okay, practical lifestyle stuff. And what about light therapy? That seems like the classic SAD treatment.
Yes, light therapy or phototherapy is definitely in there. The notes actually listed as regular management. This typically involves daily exposure, usually in the morning, to a special bright light source, a light box or a lamp, designed specifically to mimic sunlight at a certain intensity.
Aha.
Psychotherapy is also highlighted as important. Things like CBT cognitive behavioral therapy, but also general counseling or psychodynamic therapy are mentioned. The goal here is to help patients develop coping strategies, manage symptoms, and maybe address some of the behavioral changes that come with SAD.
So lifestyle, light therapy, talking therapies. What about medication?
Right, prescribing management. Now, this is interesting. The notes explicitly state there's limited evidence for the effectiveness of antidepressants, specifically for SAD. That's an important point.
Really? Despite it being a form of depression?
Yeah, that's what the notes specify for SAD itself. However, if medication is deemed necessary, SSRIs are mentioned as the preferred first choice. The notes also list some alternatives, things like propranolol, melatonin itself, or that newer drug, agomelatine. And for more severe cases, they suggest that combining light therapy with antidepressants might be the way to go.
Interesting nuance about the limited evidence for SSRIs specifically in SAD, even though they're the go-to if meds are used. Do the notes compare different therapies?
They touch on it. They mentioned some studies suggesting CBT might actually lead to lower depression severity compared to using light therapy alone. And that research is ongoing to compare these approaches more directly.
Okay, and what about herbal options? Is St. John's wort mentioned?
Yes, it is. St. John's wort gets a mention. It's noted as being effective for mild to moderate depression in general, and potentially at least as effective as light therapy for SAD. But, you always have to be careful about interactions with other medications with St. John's wort.
True. Any other treatments mentioned?
They briefly touch on some experimental things, like using blue light specifically for therapy and combination approaches like light therapy plus CBT. An antidepressant called bupropion is specifically suggested as potentially useful for preventing recurrence. And agolpanatin is highlighted again as a newer option with a different mechanism, melatonin agonist, and 5-HT2C antagonist that shows potential benefits.
Okay, that's quite a range of options. So a memory strategy for management could be thinking in layers. Start with the lifestyle base, add light therapy and/or psychotherapy, then consider medication, like SSRIs, remembering that limited evidence point if needed, and then maybe think about combinations or those alternative options like bupropion for prevention or agomelatine.
That's a solid framework. And the notes absolutely stress that the final choice really depends on how severe the symptoms are, what the patient prefers, and always consulting a healthcare professional for personalized advice.
Right. Makes sense. So what's the overall outlook for someone diagnosed with SAD? What does the prognosis look like based on these notes?
Generally speaking, the prognosis is described as good with appropriate treatment. That's the important caveat.
Okay.
The notes are realistic, though. They state it is a recurrent and chronic condition. That seasonal pattern tends to come back year after year if it's not actively managed.
So you have to expect it might return each winter.
Yes, that recurrence is part of the definition, really.
Right.
However, the positive side is that the notes emphasize with proper treatment. They specifically call out light therapy and psychotherapy again. People can expect symptom relief outside of the winter months, and many individuals do respond well. The key takeaway is that ongoing management and using preventive strategies are really vital to lessen the impact when winter comes around.
Good to know it's manageable, even if it tends to recur. Okay, final area. What happens if SAD isn't treated or isn't managed well? What are the potential complications the notes warn about?
Yeah, this is important. If it's left untreated or managed inadequately, the notes highlight some pretty significant potential consequences. It can lead to a really substantial impairment in a person's quality of life and their ability to function day to day.
How might that actually show up in someone's life?
Well, it can manifest as significant social withdrawal, leading to feelings of isolation. It can cause problems at work or with studies' occupational issues, and it can put a strain on relationships.
So it can really ripple outwards and affect multiple parts of life.
It certainly can, yeah. The notes also state that untreated SAD increases the risk of developing other mental health disorders down the line, particularly major depressive disorder becoming non-seasonal. And, in more severe cases, untreated SAD can potentially contribute to thoughts of self-harm or even suicide.
Those are obviously very serious potential outcomes.
They are. And the notes wrap up this section with a really crucial concluding sentence, perfect for revision and practice. Early intervention and getting appropriate treatment are absolutely essential to prevent these complications and to promote the person's overall well-being.
Right. So boiling it all down, the prognosis with treatment is generally positive and it's manageable, but ignoring SAD or not managing it properly carries some really significant potential risks to health, functioning, and overall quality of life.
That's the critical message, yes.
Yeah.
It's definitely a condition that warrants proper attention and management.
Wow, okay. That was a really thorough deep dive into seasonal affective disorder, pulling out all those key details from the notes. We've covered, well, everything really from the basic definition, the fascinating causes involving light and biology, who's most at risk, how it works in the body, what it actually looks like symptom-wise, especially those key ones like carb cravings, how it's diagnosed clinically by ruling other things out, the whole range of treatments from lifestyle and light to therapy and meds, the generally good outlook with treatment, and importantly, the serious complications if it's not addressed. Understanding those key features, that seasonal pattern, those specific symptoms, that really does feel like high-yield stuff for revision.
It really does highlight that intricate connection between our environment, like light, and our internal biology, doesn't it? SAD is such a clear example of how something seemingly simple, like light exposure, can have such a profound effect on our mental state and health. It really makes you pause and think about how interconnected we are with the world around us.
That's a very powerful thought to end on. Definitely food for thought. Now, if you listening are looking for more resources to help with your revision, or maybe want to dive deep into other topics like this one, there are some excellent places you can check out.
Yes, absolutely. Definitely take a look at pastthemsra.com.
And for some great free resources specifically designed to help with your studies, head over to freemsra.com.
Yeah, those sites can be really invaluable for consolidating understanding and just getting prepped effectively.
We really hope this deep dive into seasonal affective disorder has been useful for you. Feel free to revisit your notes or listen back to this discussion whenever you need to refresh those key points. Keep up the great work.